Issues with the sound, just let me know, okay? All right, so my name is Patrick Dickin, and this is my presentation of Picking Up the Pieces, Navigating PICC Line Use and People Who Inject Drugs with Infective Endocarditis. Thank you all for coming today. Here's a little about me. I'm a second year MD MPH student at LSU. Before school, I worked as an ER tech at Austin West Bank for 2 years, and I am passionate about infectious diseases, epidemiology, and improving patient care and outcomes. I have no financial disclosures, but I am doing this as part of my practice experience course at LSU. Some competencies I have to meet are communicate appropriate public health content, both in oral and through writing and oral presentation, and effectively communicate epidemiological information to diverse audiences in diverse settings. I made some learning objectives just so the presentation stays organized. In general, it will be as follows: describe a PICC line and OPAT, describe a substance use disorder, describe current guidelines by professional societies, compare different ways to complete OPAT and people who inject drugs with infective endocarditis, examine psychosocial factors that affect people who inject drugs, describe harm reduction in its basics, examine healthcare system challenges for the situation, and discuss the ethical and legal challenges for the situation. References will be at the bottom left, and competencies and learning objectives will be at the right. All right, so infective endocarditis is a complex, life-threatening infection caused by bacteria entering the bloodstream and attaching to blood vessels in the heart, the heart's lining, or most commonly in one of the heart's valves. And about right there. Risk factors include heart valve disease, congenital heart disease, previous surgeries, or IV drug use. Treatment includes, one second, let me let someone in. And we just got started. A lot of people on Zoom. All right, sorry about that. All right, so treatment of infective endocarditis include IV antimicrobials through a PICC line or heart surgery. If left untreated, it can cause immune complex disease and vegetations, the circles here, to dislodge, causing things like heart failure, strokes, and organ damage. PICC line stands for a peripherally inserted central catheter. It's essentially a long, thin tube that inserts into the vein in the arm and goes to the heart. One end stays near the top of the heart, and another stays outside the body, typically the arm. PICC lines were first used for IV nutrition in 1975, but have been adapted to be used for other things. It's used for things like chemo, giving long-term blood products, and outpatient parenteral antimicrobial therapy, otherwise known as OPAT. They are called for when the patient will need long-term treatment, generally longer than 2 weeks, involving IV access. And they're great because they can reduce needle sticks, provide easy access to the patient's bloodstream for giving meds, and allowing for meds to be given at home with the right training. They allow for better quality of life since patients can return to semi-normal life, and this improves patient satisfaction, increased adherence to treatment, and reduces the need for long inpatient hospital stays. And I found this cute little cartoon made by some artists targeted towards kids with cancer. It's like, this is my PICC line. It looks like a little wing. It has a tube that goes inside my body. It can be used to give meds, give blood, and give my body a drink, and careful not to get my PICC line wet. And OPAT was first used to treat cystic fibrosis in the 70s, but it has been adapted to treat complex infections. These complex infections can include things like sepsis, osteomyelitis, and infective endocarditis. Typically, when patients get treatment, they are admitted to the hospital for IV antibiotics and eventual supportive care, and they are given this until they are stable enough to be sent home or to a step-down facility. They can then go through OPAT for about 2 to 6 weeks, depending on the type of organism involved and the severity of the condition. Get that for me? Thank you. Pathogen-specific recommendations are given by the American Heart Association and the Infectious Disease Society of America. And in this picture here is NFL kicker Lawrence Steins. from the Tampa Bay Buccaneers. He had to undergo OPAT due to MRSA-related osteomyelitis in his foot. And you can see his PICC line here in his arm and a little bowl full of antibiotic solution that he can use to give himself. Some risk and complications include secondary infections, accidental removal, more bleeding, blood clots, device failure or breakage, and there's a theoretical potential for misuse of that PICC line for people who inject drugs. But does this risk factor come from true evidence or stereotypes about people who inject drugs? We'll cover this later. A substance use disorder is a chronic disorder with episodes of remission and recurrence. It is characterized by a loss of control of the substance use, having a compulsion to use a substance, and continuing to use the substance despite the physical and mental harm it brings. There are many subtypes, but I'm going to focus on opioid use disorder in this presentation. Substance use disorder can be debilitating as it interferes with everyday responsibilities, health, and overall well-being. And due to this, it is defined as a disability under the Americans with Disabilities Act, or ADA, under specific circumstances. I'll cover this more on this later. Now, about 10% of all infective endocarditis cases are associated with IV drug use here. However, the number of these deaths have increased exponentially in the last few years. One study in Oregon showed that there was an 18-fold increase in hospitalizations due to complex infections by IV drug use between 2008 and 2018. Another study showed that rates have increased across the US as a whole here. And another showed that it affects mostly patients younger than 35 years of age. On a more national level, drug overdose deaths rose from 2019 to 2020, with over 100,000 people in the US dying from overdoses. And studies have found that there was a steady rise in overdose deaths due to the COVID-19 pandemic. This line shows about when the pandemic started, and it shows a dramatic increase in the deaths. This period effects is thought to happen because of the unique stressors seen during the pandemic, isolation, and disrupted access to healthcare and the continuity of care during the pandemic. On a more local level, there's more limited historical data, but all opioid-related deaths follow the same trends. Here, it follows the same period effects. And the highest rates are seen in Jefferson, Lafayette, St. Tammany, and Orleans parishes. And it affects about the same age group as on a national level. Some psychosocial factors considered include the fact that many people who inject drugs are unhoused or have an unstable living situation, have co-occurring mental health issues, face stigma every day because many consider a substance use as a moral failing instead of looking at it as a disease. And many come from diverse backgrounds and face racism and discrimination daily. This can cause many biases to intersect with each other, leading to worse overall health outcomes. And many come from disadvantaged backgrounds, which could affect transportation and some support needs. And just to show how close this is to home, here's a map. Right here is UMC and LSU. And this picture right here was taken right next to campus. Pass it every time I come into LSU. Many of the patients are treated well by hospital staff until they disclose that they have a substance use disorder. Many qualitative studies have shown that these sometimes punitive negative experiences correlate with having a substance use disorder. To curb the stigma, there has been a push in the literature to use patient-centered language instead of language that inherently blames the patient for disorder they have. Okay. For example, instead of saying a drug abuser, say a person who uses drugs. Instead of saying junkie, say person who injects drugs. Instead of saying clean, say person who has used drugs. And here are two examples of patient experiences from these qualitative studies. In general, they tend to be a little stricter with you. They tend to be more short-tempered with you. They tend to presume what you need instead of having a conversation, right? And they do not get to know you as a person. They just assume that we're all going to do the wrong thing. It's just not true. So given all these complex factors, can we trust someone with a substance use disorder with a PICC line for OPAT? It has been heavily debated among professionals since the early 2000s. This first example from 2001 is from Dr. Mallon, an ER doctor in California. He argues that people with a substance use disorder who undergo OPAT might be problematic due to the overwhelming temptation to use the line for injecting drugs, the contamination from unclean needles and drugs, and other health complications such as infections or an air embolus. This opinion piece was quickly countered by Nassim Ratzazi, a fourth-year med student at the time of publishing. She cites that doctors have a duty to care for the patient in a non-discriminatory manner, to keep healthcare costs as low as feasibly possible, and to respect the patient's wishes and values by speaking with the patient in a shared decision-making model. So she argues that it can be done in a supervised home to ensure lower costs. Both these articles are showing their age, though, using words such as heroin user instead of a person with a substance use disorder. So let's look at something more modern. So what does modern research say? Some say it's still too risky, while others say it can be done in some select people. There are many studies on both sides, so let's look over them, their strengths and weaknesses. This is one study in 3 hospital systems showing OPAT is too risky in people who inject drugs. They showed a high recurrence of infective endocarditis in people who inject drugs, particularly in patients who abuse their PICC lines. Some strengths of the study are it had a decent sample size for what it's researching. It is a long-term retrospective cohort study, and it shows secondary results that infective endocarditis has an higher odds of occurring in people who inject drugs, their second time of getting infective endocarditis. And this study acknowledges their weaknesses in the literature. But let's explore some of the weaknesses that they disclose and the ones that they did not disclose. So in this study, it had 3 major problems. One, the definition of PICC line abuse is very broad. It relies on suspected misuse as reported by the clinician instead of using something measurable or asking the patient directly. Number 2, it had a median time of 1.23 years between the first and second episode of infective endocarditis. This leaves it hard to conclude that there's an actual correlation between the 2 things being measured, since they could be separate events entirely. Number 3, it had a low referral rate to supportive or substance use treatment programs, which further supports that the notion that the second episode of endocarditis could be a separate event entirely. However, one common trend among all these studies is they don't blame the individual with the substance use disorder for these increased complications. Instead, they suspect that complications come from the lack of proper follow-up and continuity of care, lack of psychosocial support services, and the lack of adequate outpatient addiction services. To support this, Marks et al. Showed that addiction medicine consult rates decreased remission rates, which could signal better health outcomes, as seen in this graph on the right here. A more visual study by Bernot and Milton used a journey mapping, a technique typically used in business and marketing, to illustrate a patient's journey in receiving care. And 3 main themes emerged. And the first theme showed that early addiction treatment and intense outpatient care precedes periods without rehospitalization. In the first map on the top right, subject 3 was a 35-year-old non-Hispanic white woman. She had a brief 3-week hospitalization, require intensive care, early addiction treatment, and consultations from infectious disease and addiction medicine teams. She then spent several months in post-acute care, completing her antibiotic course, continuing addiction treatment, and engaging in rehabilitation. This was followed by nearly 10 months of intensive outpatient care, during which she continued seeing specialty providers and remained substance-free and out of the hospital until the drug use happened again. In the second map on the bottom right, the subject 101 is a 42-year-old non-Hispanic white male. He was hospitalized in intensive care at a community hospital before transferring to another hospital for potential heart valve surgery. He did not receive addiction treatment as no addiction consult services were available. He was discharged directly home with limited opportunity for outpatient follow-up and had no addiction care plan. He did not seek community resources, disengage from care, and return to substance use. This resulted in a pattern of rehospitalizations due to his untreated substance use disorder, and you can see the up and down pattern at the bottom right here. Note the time frames associated with these maps right here. At first, I questioned if the study changed the graphs to make the results look better. But if you look at the acuity of care right here in the same time frame, The patient who received addiction medicine treatment needed less intense care and stayed out of the hospital longer. The second theme showed that patients left and re-engaged in care due to unmet pain needs, unmet pain and withdrawal needs, discriminatory behaviors by healthcare staff, and prolonged periods in care triggering underlying mental health comorbidities. This first patient left care 3 times in their opioid use disorder endocarditis due to undertreated opioid withdrawal. After delays, she was admitted for emergent valve replacement surgery within days. Post-operatively, she had a long hospitalization followed by post-acute care and intensive outpatient follow-up, where she engaged in addiction treatment and cardiac infectious disease care. And the second patient, this participant experienced several long periods of remission from opioid use disorder and sought out addiction care promptly following her return to substance use on multiple occasions. In one particularly poignant moment, she describes going out to meet her dealer to continue to use drugs, but instead she went to the emergency department for care and trying to reconnect to that addiction care that she needed. The third theme found showed that patients leaving intensive outpatient care and returning to substance use often directly precedes rehospitalization. Patients leave this care due to transportation issues, other life obligations such as pets, work, family matters, and further unmet pain withdrawal needs. This patient up here, after his first episode of opioid use endocarditis, he experienced homelessness and he had to jump from family member to family member. This instability made him attending follow-up appointments difficult, causing lapses in care. Consequently, he had seizures from missing his anti-epileptic medications and returned to alcohol and cocaine use due to his familial triggers, leading to rehospitalization. In this bottom patient, this individual received care in New Hampshire for about a year after his initial opioid use disorder associated endocarditis, but continued misusing opioid pain medications while on buprenorphine, sorry. He reported being expelled from his treatment program instead of receiving more intense addiction care, leading to increased substance use. A return to injection heroin and recurrent mitral valve endocarditis, necessitating another lengthy hospitalization. There are some modern studies showing that OPAT can be done in people who inject drugs with unique hospital approaches. In this first study up here, they screened people who inject drugs and they used a PICC cover for their PICC line. Now, there are some weaknesses associated with this, and it's the ethics of using a security seal only in people who inject drugs. They thought the authors of the study can see it being used as essentially a red flag in any outpatient treatments as, hey, I use drugs, and people will discriminate against them. The second study showed that it can be done, but it had a lower sample size. And this third study showed that it could be done as well with addiction treatment, but it had hard exclusion criteria right here, such as safe housing, are they engaged with addiction treatment, do they agree to return to this clinic, and they return to their infectious disease appointments, all relying on their own transportation. And then there was a final literature review examining 10 studies and their patient outcomes for people who inject drugs who went OPAT, and they showed that 72 to 100% of people who inject drugs successfully completed OPAT. And they found that the rate of misuse of the catheter was low, despite the clinical perception that PICC misuse would be inevitable among people who inject drugs undergoing OPAT. Yeah. Some caveats. Many of the studies from both sides have a very low sample size, sometimes less than 10 or 50. They do not have referrals to proper addiction medical specialists on an inpatient and outpatient level, and this reflects the lack of available addiction medicine specialists overall. Many healthcare staff are unfamiliar with the ins and outs of addiction medicine, and many healthcare centers lack multidisciplinary care and struggle with continuity of care. Given these, what do the professional associations recommend for someone without a clear answer? So for historical purposes, to show how the tone has changed from 2004 to 2018 to 2022, these are the 2004 guidelines from the Infectious Disease Society of America. Patients who are likely to abuse a vascular access system are poor candidates for OPAT, and a skilled nursing facility might be the appropriate model for care. And they recommend that IM injections or removal of the catheter for each time that they need their treatment might be the most appropriate, or another computerized system if the hospital system has that. And they comment that the patient's ability to adhere to the prescribed treatment with the threat of unauthorized vascular access will determine whether therapy outside of the hospital setting is advisable. And they didn't elaborate further until 2018. In 2018, they published guidelines for general infective endocarditis, but they can't make any recommendations about whether people who inject drugs may be treated with OPAT at home. And decisions should be made on a case-by-case basis. Injection drug use was found to be a risk factor for vascular access complications of IR of 3.3. However, this is for general vascular access complications and not narrow on the PICC line itself. It's later stated in this guideline that this is low quality evidence for this increased vascular access complications for people who inject drugs versus non-people who inject drugs. It gives providers details to consider, like more psychosocial factors, and it gives alternative treatments such as discharging patients to a skilled nursing facility, sending patients home without a PICC line, but bringing them to outpatient facility for each administration of their medication, or keeping them in the hospital for the duration of their entire treatment course. They recommend some secondary treatment options, but say it must be done on a case-by-case basis. Some cases with oral antimicrobials and injectables have been shown to work. One study showed that oral antimicrobial therapy was non-inferior and less liver toxic, but it doesn't work in all cases, however. Some complicated infections and polymicrobial infections, this might not work, and it doesn't work in patients who have impaired GI absorption. Professional society guidelines such as IDSA cannot make direct recommendations for or against these treatment options, and they reflect that it required shared decision-making instead of a paternalistic attitude. The key is not to make assumptions about what the patient will do, but to talk to them directly and figure out what they want to do. The most recent statement by the American Heart Association was in 2015 guidelines. They made a small recommendation to referral patients with a substance use disorder to treatment programs, but didn't really elaborate further until 2022. They uploaded a scientific statement called the Management of Infective Endocarditis in People Who Inject Drugs, reflecting how little details they had in the 2015 guidelines. It was much more thorough. It had considered multidisciplinary approaches, better history and physicals, medications to treat opioid use disorder, partnerships with community clinics, factors considered such as psychosocial factors, harm reduction education, and secondary treatment options. So they recognize that the methods that have worked for other institutions, such as using a specialized multidisciplinary endocarditis team, including but not limited to infectious diseases, cardiology, cardiac surgery, addiction medicine, psychiatry, nurses, pharmacists, and social workers. There have been even calls to include more, such as a dentistry, peer support workers, systems navigator, and a family or primary care physician. But at bare minimum, you want addiction medicine, ID, or cardiac surgery. They recognize that the lack of addiction medicine has been siloed from the mainstream healthcare models, and that they also comment that treating infective endocarditis alone without treating the underlying substance use disorder fails to treat the underlying cause of the infective endocarditis. They recognize the importance of a shared decision-making model between the healthcare team and the patient compared to a paternalistic one. They encourage a better history and physical. So instead of asking the binary, do you use drugs? Asking more, what do you use? What have you used before? What are you currently using? How much do you use? How do you use it? And ask them about their previous engagement with addiction treatment experiences, and asking about other overdoses and other injection complications. It helps determine the risk of withdrawals and other injection-related infections, and they encourage a thorough skin examination to check for previous and current injection sites for inflammation or infection, check the liver for cirrhosis, look at oral health, and assessment of the substance use withdrawal using the clinical opioid withdrawal scale or CAPS. and being mindful of the stigma and using non-judgmental first-person language on this later. So COWS is this little scale they have here. You can look at your patient and figure out how severe are their withdrawals. Are they sweating? Are they restless? What is their pupil size? Do they have bone and joint aches? Do they have a runny nose, minus if they have a cold? Goose flesh skin or just goosebumps? Anxiety, or are they irritable? Are they yawning a lot? Are they shaking? Do they have GI upset? And what is their pulse rate? It can give them an idea of, where they are in the withdrawals. And they give more questions asked patients, such as what drugs are you injecting? When did you last use drugs? How are you using it? How do you prepare or cook your drugs? And have you ever had any other complications such as infections or wounds that won't heal properly? They give healthcare staff an idea of what complications to think of, such as environmental contaminations, non-sterile injection techniques, using saliva on the needles, or lemon juice in the preparation. An example of this is oral floor contamination from the practice of licking their needles. And there's other microorganisms that need to be aware of in these specific factors as well. Some patient experiences here. This is one where shared decision-making helps the patients in need. There's no way that I could be home right now and not try to get heroin. At least I know what's being put in my body. If I were to leave this hospital right now, I don't think I would make it. But there's, on the other side of the coin, is where shared decision helps patient autonomy. It's autonomy. He makes me feel like he really listens, like he really cared, and it gave me some reassurance. People who use drugs are treated as non-persons or children in a lot of ways. The biggest thing I can think we can offer anyone is a choice. There's a dignity in offering all the information and having people choose that. They also recommend medications for treatment of opioid use disorder. They advocate for getting the medications and not providing it can violate the ADA, or they comment that. They comment that judgment-free care if the patient has a relapse and encouraging reentry in the treatment program. And they advocate for educating clinicians and getting their DEA license to describe buprenorphine, at hospital discharge. And the training is free and it's online. They can give to doctors, PAs, nurse practitioners, pharmacists. They recommend partnerships with community clinics, community opioid treatment programs, addiction treatment programs willing to set patients receive, forming partnerships with programs willing to set patients going through OPAT, forming partnerships with patient services such as transportations or medication pickups, and forming partnerships with skilled nursing facilities. But discrimination is very common, even though it has been defined to violate the ADA. And then they form partnerships with medical respite programs for unhoused patients, because currently there's no official medical respite programs for homeless patients in Louisiana. Other states typically have 1 to 3. Some other factors to consider are patient preferences and informed consent, the feasibility, do they have health insurance, or is there availability of residential addiction treatment facilities, social work, case management, find that they have resources at home. Are they engaged with treatment? Are they going through harm reduction steps to keep themselves safe? Is their home environment safe? Do they have a safe place to live? Do they have sober supports to help them? Do they have running water, electricity, or working telephone number? And can they get transportation to and from appointments? They provide this fancy flow chart here to help clinicians with their treatment guidelines. So first, offer all patients 6 weeks of IV antibiotics. Limit the opportunity for unplanned discharge by working together with your patient and make them comfortable. Provide patient-centered decision-making regarding antibiotic treatment options. Is 6 weeks of IV antibiotics achievable? If not, then provide it in a supervised setting. Or if it is, but it turns out it's not in a supervised setting. And are there any contraindications to oral medication? If there is, provide injection antibiotics. And if not, provide oral antibiotics. But if you provide oral antibiotics, you want it to be on an on-site pharmacy and give it to them at the site of discharge so they don't have any logistic issues getting that medication. So they advocate for harm reduction as well. Harm reduction is a public health strategy aimed at minimizing the negative health, social, and legal implications associated with high-risk behaviors, not just drug use. It focuses on harm reduction without necessarily eliminating the behavior, emphasizing practical, non-judgmental approaches to improving safety and well-being. It's seen in everyday practice, including but not limited to seatbelts, so you don't fly out through the windshield if there's a car accident, helmets, so you can protect your head at a work site, sunscreen, so you don't get sunburned while out in the sun, PPE, such as wearing masks at the hospital, and then Narcan in the case of drug use. It's not condoning or supporting risky behavior such as drug use, but it is keeping you safe if you need to do that behavior. So they also give some key points for safer injection drug use. Do not lick your needles, do not lick your injection site, keep it all sterile, and they provide this nice chart for patients to look at and for clinicians to figure out what organism might be related where. Treatment for HIV, hepatitis C, if it applies. They give advice on what to give in harm reduction kits, and they encourage providers to prescribe naloxone upon discharge, although you can get it over the counter now. Some patients might have trouble getting naloxone over the counter, but due to logistical cost issues. Some more local resources in Louisiana, they have the New Orleans Travelers Aid to assist unhoused patients. Trustero Network for Harm Reduction, it provides fresh syringes and injection supplies, wound care kits, Narcan, and education training, linkage to full care. Safety manuals. This is a 70-page safety manual on how to safely inject for drug users, and making sure that the patient has a backup. They have the Never Use Alone hotline and the Brave app, where patients can call the number, give them their information, say, hey, I'm about to use drugs. I don't want to be alone just in case of overdose. And if they don't respond, then they'll send EMS their way. And this is an example of how harm reduction could have prevented harm. It highlights the importance of medical staff asking the right questions and knowing the ins and outs of substance use. And it gives opportunities to educate patients about safer injection practices.
But when patients use heroin in the United States, they generally use white salt heroin, heroin hydrochloride. Heroin hydrochloride, white salt heroin makes up the vast majority of heroin that is injected by your patients and mine. It's water soluble. What do? You take it, you put it into your cooker, you mix it with your diluent, you heat it up, you put your filter in, you draw the drug through the filter, and you inject it into the vein. Well, there's a lot that we need to consider there. Well, that's important because there's a number of other patients who use black tar heroin, acetylated heroin. Acetylated heroin, black tar, makes up about 10% of the heroin use in the United States, larger portions outside of the United States. But what's important about black tar heroin is that it's not soluble in water. It requires an acidic diluent for injection. In the United States, this generally means a sterile citric acid packet picked up from the needle exchange facility or the underground safe injection site, or even if you're lucky enough from the pharmacy or even the supermarket where you can get a sterile citric acid packet to turn your diluent acidic so that you can safely inject this into your vein. But so many of our patients don't have access to these sterile diluent modifiers. So many of our patients have to substitute non-sterile acidic diluents to inject their drugs. Where do they find these non-sterile diluents? They find them in fruit juices. They find them in lemons left on the counter. They find them in vinegar that's in the closet in the kitchen. And what's more important is that this practice of using acidic diluents has found its way not out of the black tar community and found its way into the heroin salt, the white heroin community. So many of your patients are using acidic diluents for injection, and failure to ask that question can lead to terrible, terrible results. So what happened with Melanie?
Well, I've gone to the emergency room a few times because my eyes kept turning red. Every time I went, doctors just told me it was pink eye over and over again. I would go and they'd say it's pink eye, but kept being red.
It's pink eye. It's pink eye again and again. It's pink eye. And I'm an attending emergency physician at an academic level 1 trauma center with 1 billion residents. My evaluation of pink eye consists of me walking through the room like this as the resident writes the note and they kick the patient out. But what we didn't do was we didn't ask the question. Melanie didn't have pink eye. Melanie, who we knew to be an IV drug abuser, Melanie was using non-sterile acidic diluents to inject her heroin. What was Melanie using? She actually lived in a fairly affluent family, and her mom every morning would cut lemons for her iced tea and squeeze the lemon in and leave the lemon on the counter, and Melanie would come down and take the lemon and use it as the acidic diluent for her heroin before injecting. And why is that a problem? It's because every time she was doing that, she was injecting fungal spores directly into her bloodstream until those fungal spores found themselves to her eye, and that's not pink eye, that's fungal endophthalmitis. And we missed it. We missed it 3 times when she presented to our emergency department until the 4th time. And Melanie had to undergo enucleation. Melanie's eye was taken out by our ophthalmologist. Melanie lost her eyes.
Nobody ever tells you that heroin can take your eyes.
Nobody ever tells you that heroin can take your eyes because none of clinicians know what it means to inject heroin, how you inject heroin. Our clinicians don't understand that our patients are seeking out the acidic diluents for their injection, and they're using the lemons left on the counter by their mom, and they're suffering fungal endophthalmitis, fungemia, fungal spinal infections, all because nobody ever asked the question, what are you using to dilute your drugs in? Is it fruit juice? Is it Mountain Dew? Is it citric acid packets? What are you using and why? And then speaking with the patient, hey, listen, I know you're using fruit juice. Do you know that you don't need to do that? You can use water. It's okay. Oh, you're using fruit juice. You're using black tar. Well, let me provide you with the ability to obtain sterile citric acid packets. This is what harm reduction is. All it is starting with a simple question. What do you use to shoot your heroin with and why? And it begins a conversation, it begins a relationship with your patient, and it leads to better outcomes for our patients. Melanie, a beautiful young girl who started on Percocet from a field hockey injury, lost her eyes because nobody ever asked her what she was using to shoot her heroin.
All right, so for those on Zoom who couldn't hear, essentially the ER physician had this patient that came in with pink eye. But she came in 3 times with that same pink eye. And the attending physician essentially says, yeah, I'm an ER physician. I walk in and out, and then the resident does all the work. But what they forgot to ask the patient was, how do you use your drugs? What the patient did is to dissolve her heroin, she used lemon juice, and that caused fungal spores to go into her bloodstream, and it went to her eye, and she lost her eyes. It's a great video. Y'all should watch it after this meeting. In the United States. So let's move on to the trans-theoretical model of change and motivational interviewing approach. Harm reduction approaches can be thought of a meeting the patient where that approach, instead of forcing them to go cold turkey in abstinence. While abstinence-based programs might work for some individuals, it doesn't work for every individual. You can use the trans-theoretical model of change to gauge where the patient is at in their stage of change. And it is one of the many behavior models used to evaluate someone's readiness for change, and it's divided in these stages: pre-contemplation, contemplation, preparation, action, maintenance, and termination. At any point in these, you can relapse and go back to a previous stage of change. So for pre-contemplation, it's like, nope, I'm not going to change. Contemplation, I might change. I'm thinking about it a little. Preparation, I'm preparing to change, but I'm not there yet. Action, I'm actively changing. And maintenance is I'm actively upkeeping this change that I'm doing. You can measure this with self-evaluation rulers, such as readiness rulers, or make a decision balance worksheet, such as here. You can ask your patient, are you ready for change? And where they rate themselves on a scale. On the scale can give you an idea where they're at in their stage of change. And you can use motivational interviewing techniques by asking why the patient didn't rate their readiness for change lower. This opens their reasoning for change and can give you an idea of what to work with. And it can help you encourage them to change behaviors and that might put them at risk at large. Since many patients come from many different backgrounds, not every patient will be ready for change for intrinsic or extrinsic reasons. Motivational interviewing was first described in 1983 as a brief intervention for problem drinking, and it works by activating patients' own motivations for change and adhering to treatment. Compared to no intervention, it led to a decrease in the extent of substance use at post-intervention up to 1 year, and it was a meta-analysis done for motivational interviewing compared to no intervention. But if you combine motivational interviewing with other substance use treatments, such as medication, it might lead to better results. Conversations about behavior change arise when you and your patient are considering doing something different in the interest of their health, and the way you talk to your patients about their health can substantially influence their motivation for behavior change. People are rarely completely unmotivated to change. I've worked in healthcare before, and I've heard things like, he'll be here OD'd again next week. He doesn't want to change, he just wants his next hit. People deep down might want to change, but they know what's harming them, but they may not know where to start given these complex psychosocial factors. Motivational interviewing can help patients find reasons for change and help them engage in these behavior changes. So how do you rule at motivational interviewing? You got to resist the urge to correct them. Don't tell them that what they're doing is wrong. They already know that, but they might dig their heels down and dig into it more. Avoid telling them, instead guide them. Understand where they're coming from. Seek to understand their values, their needs, their abilities, and their motivations. Listen to your patient with empathy. Seek to understand their values, needs, abilities, motivations, and empower your patient. Work with them to achieve goals and identify the techniques to overcome their use disorder. How you communicate means a lot. Listen carefully, asking about other options being considered, explore the pros and cons of their behavior, offering what you know, but leave the decision to them. You can use ORs, such as asking open-ended questions rather than yes, no. It allows the patient to give more information, including their feelings, attitudes, and understandings. You can affirm their strengths and move them into a positive direction to prevent them from overcoming self-sabotage or other negative thoughts. And you can reflect what they say to express ambivalence, and then you can summarize to let the patients know what they are being heard. And you can be smart with motivational interviewing by using this acronym that they made here. You want to listen for change talk from your patients. If you hear your patients arguing for sameness, or you're trying to convince them to do something, then you're doing it wrong. Vague statements like, I'm going to quit tomorrow, or I'm going to stop using drugs aren't good enough and are prone to leaving you frustrated that you couldn't complete the goal that you set out to do. Instead, you use the trans-theoretical model to gauge where the patient is on their stage of change and set goals that way. Good goals in this case of drug use would be, instead of injecting a drug 3 times a day, I'm going to inject it 2 times a day and use coping strategies or medication for 1 week. This is specific because it's not vague, measurable since you're counting the amount of times you're using, and it's achievable by specifying how you're going to do it. It's realistic because it's unrealistic to force someone to just stop using drugs and just to say no. And it's time bound. You gave yourself 1 week to do it. And most importantly, if the patient comes back saying 1 week later that half the time they can only do 3 times and the other half they do 2, that's still fine. That's still progress, and it should be praised as positive feedback. But this is limited by uncontrollable psychosocial factors and other healthcare system challenges. Some healthcare system challenges are bias and stigma. Patients' experiences with bias and getting treated in a judgmental way. Quote here is, I think you get labeled, as a kid, they would tell you that's going on your permanent record. That's how you feel. Like this is going to follow you everywhere you go. I think people view it differently. I think that there is judgment. You'll get treated like a second-class citizen or a patient in a psychiatric hold despite no acute mental health issues, such as getting searched, belongings taken away, cell phones taken away, and unnecessarily safety sitters. And it's important to treat them in a non-judgmental manner, as has been shown to build trust and improve patient chances for substance use disorder remission in numerous qualitative studies. Such as here, Dr. X in the study was the first person in my lifetime to sit across from me and look me in the eyes and tell me that she believed in me. And that she has known me only for a couple of weeks now and talking to me every day, She believes 100% that I can get past the withdrawal, and not only that, but get sober and stay sober. That means a lot to me. Another healthcare system challenges is healthcare staff burnout. As staff burnout, biases might creep out. Education on substance use disorder alone is not enough to stop these biases, and staff need role support to help them build a therapeutic attitude with their patients with a substance use disorder. This is a great study right here in nurses. They did a multivariable regression analysis and explored the relationship between education, role support, and a therapeutic attitude by nurses. And they found that if you increase education, the therapeutic attitude does not start getting bigger until you add more role support. As you add more role support, more positive influences, nurses who know what they're doing in treating substance use disorder, the therapeutic attitude goes up. Okay. Without enough support, staff might reflexively rely on biases, even though morally they recognize it's wrong, and lead to quicker burnout as well. Another healthcare system challenges is resource allocation. While more providers are getting certified to prescribe opioid use medication, it isn't enough to keep up with demand, nor does it acknowledge the complex psychosocial factors in play. And there's not enough opioid treatment centers with modern practices. People who inject drugs with infective endocarditis are forced to stay in the hospital for their entire treatment length stays, and it strains hospital resources and costs taxpayers thousands of dollars, especially if the patient is on Medicaid. So expanding access to having more providers that can prescribe medications for the opioid use disorder and tailoring treatments for people who inject drugs with endocarditis has been shown to be more cost-effective in retrospective studies and in simulated models. An estimated $6 billion could be saved annually for hospitals for an estimated 7,500 patients who inject drugs every year, assuming the patients are eligible for partial oral treatments as well. Some ethical considerations to think about are, is it wrong to deny a person who injects drugs outpatient therapy despite it being standard of care? Do we force other patients to sign abstinence contracts for things such as smoking, high blood pressure, or blood sugar control? And how does this limit patient autonomy? How do we balance care and harm reduction with societal and institutional norms? From the provider's point of view, he doesn't want the patient to die or get harmed, and he doesn't want to get sued. And this doesn't help because there's no clear-cut institutional guidelines like at LCMC. From the patient's point of view, they're not getting their pain or withdrawal needs met, which only furthers their distrust in the healthcare system at large. It could lead to patients not seeking medical care until their medical issues are advanced, such as in the case of infective endocarditis. Balancing these dilemmas with shared decision-making, gauging where the patient is at, and the readiness for change, and proper documentation on the part of the provider is important for all these concerns. And what about patients who are unhoused? There's not really a good answer here. Some legal considerations in this case is, they have some legal cases going on right now. Landau versus Good Samaritan Hospital et al. Mr. Landau had a complex foot wound and was denied OPAT due to having an opioid use disorder, and was denied medication to treat his withdrawals. The provider cited hospital policies for denying PICC lines in people with substance use disorder. Mr. Landau had complications as a result and had to have his left leg amputated below his knee. The representatives claimed that the Good Samaritan Hospital et al. Violated these laws here, and Mr. Landau reported that his Dr. Kapoor, said something to the effect of, "I won't lose my license because of some junkie." That says a lot in such short words. Another legal case is McCabe versus Ohio State University. In this case, Jennifer Crispin had unmet pain needs after a surgery for an ear infection. As a result, the patient resorted to injecting a crushed up Percocet pill through her IV access line. It caused vascular damage, pill fragment emboli, and it blocked blood vessels in her lungs. It caused acute heart failure that eventually led to the patient's death. The medical center did not provide adequate addiction medicine treatment, medications, or further consults, despite the presence of a known substance use disorder. The patient's mother filed the case. Hospitals can learn the importance of integrating comprehensive addiction treatment into the care of patients with a substance use disorder to ensure holistic and effective treatment, preventing gaps in care that can lead to poor outcomes such as this. The Americans with Disability Act, some legal considerations here. People with an opioid use disorder typically have a disability because the opioid use disorder itself limits one or more major life activities. It's considered a physical or mental impairment under the ADA. Denying a patient solely based off their substance use disorder or the treatments for their substance disorder is a violation of the ADA. However, these protections are not limited, or these protections are not limited if a patient is in active treatment or has an active treatment plan with their medication and their doctor. There's no coverage from the ADA when a patient is actively using. The lines get blurry when a patient relapses, and there's no clear-cut lines for when a patient must stop using substances before these protections come in. It's more of a question for our legal team. Skilled nursing facilities have been known to overtly discriminate against people who inject drugs, and it led to a lot of successful cases being filed against them in courts. Despite these rulings, however, skilled nursing facilities have still been found to deny care to patients with a known substance disorder, but less overtly. It calls for actions from the healthcare team and hospital administrative legal team to advocate for their patients with substance use disorder. The Legal Action Center in New York provides great models for advocating for your patients with a substance use disorder. The next few slides. Here are some actions to combat discrimination by Cohen et al. The provider can refer to all appropriate skilled nursing facilities. Hospital administration can develop partnerships. Patients can file complaints with the ADA, and skilled nursing facilities can understand that clinicians can now prescribe medications to treat opioid use disorder. I like this chart because it doesn't single out one person versus the other. It provides stuff for the hospital and the skilled nursing facilities, so there's no blaming of the discrimination. They provide great flyers as well, how the discrimination happened. Recovery houses will not admit you because you take your medication for opioid use disorder. Hospitals will not provide you surgery or another procedure due to your substance use history. Healthcare agencies will not serve you because of your drug use, such as at nurse home care. And an emergency room does not offer you the medication for your opioid use disorder or connect you to ongoing substance use services to a community. They also provide a great template for the hospital's legal team or other healthcare staff that they can use to advocate for their patients with a substance use disorder. And it would just need to be reformatted for each institution, but it's a great basis as it covers about everything. Some future directions to consider is patients having access to harm reduction services, better addiction medicine services, better continuity of care in a medical respite facility for unhoused patients, and staff having access to bias and stigma education with better peer support, education on substance use disorder and harm reduction practices in professional schools, a multidisciplinary team to help them out, knowledge about community opioid programs, and backup from the hospital's legal team and administration regarding unlawful rejections from skilled nursing facilities. And this is just to show my thought process. This is something called a direct acyclic graph. It's just a complicated flow chart with the event right here, withdrawal symptoms leading to drug use, and unsafe injection practices leading to infective endocarditis. If you control for these factors right here, the lack of addiction medicine services, poor continuity of care, and lack of harm reduction services, theoretically, infective endocarditis due to drug use shouldn't happen. And in conclusion, people who inject drugs with infective endocarditis can successfully undergo OPAT if they meet specific criteria. Implementing a shared decision-making model between the patient and a multidisciplinary team, rather than relying on biases and a paternalistic approach, is essential for building trust and supporting patients in their journey with a substance use disorder or towards recovery. This collaboration approach fosters patient engagement and enhances adherence to the treatment and ultimately improves health outcomes. Meeting the patient where they are on their journey, using the trans-theoretical model and harm reduction techniques, and employing motivational interviewing to guide them are key factors in supporting their transition to recovery and ensuring better health outcomes. And if you have any questions, my email's right here. Please sign in if you didn't get a chance to, and I can send a link in the chat. I'm available for any questions. Right there. Yeah.
Important. We don't talk about that. Everybody should. Yeah.
Hi, Patrick.
Hi.
Hi. Lots of work done. Very informative. Um, just wanted to find out what are going to be your next steps with this project. Is this the
Um,
conclusion? Are you doing some additional things? I guess I also wanted to know, coming from infection control, my understanding, I was invited to this presentation, and I want to make use of, uh, you know, my experience listening to your presentation. Is there an ask of me as the manager of infection and control and prevention here at UMC? Um, is there a reason why we were invited? If I could.
um, we would probably need some help implementing some type of protocol or a policy for people who inject drugs so they can undergo OPAT. There's a lot of biases that need to be acknowledged and not a lot of guidance that the physicians have or other providers have in this situation because there's no exact policies. I've looked through UMC's and LCMC's policies and there's not a direct one.
Okay. I know that sometimes, I mean, here for those individuals who have PICs, um, we have had a tamper, uh, a tamper-proof device that we could add to the PIC so that they don't have the tendency to access the lines for drug use. And we have done those on one-offs depending on whether or not the doctor. I remember we did have a chief medical officer who was involved and engaged, and we were doing that. And I want to say we still have that available for those who request it. So, but we can definitely look to our policy to make sure that we have some language around just using that um, device.
Yeah. The only problem with that is I've read some concerns that if you do that in people with a substance use disorder and they walk into an outpatient facility, it's basically a target on their back saying, hey, I use drugs to the nurses in there. So they might be a target for some discrimination or
hmm
other biases that might leak out with some of the nurses or
I
other
want to
doctors.
say we would keep it in while they're inpatient. As far as being an outpatient, maybe not, and we may
Okay,
not have any language on that.
gotcha.
hmm Okay.
I just got a little, for this question online. Have y'all talked to any of the LSUHSC folks about any of this at any point?
I spoke with Dr. Burke with ID. She has yet to watch the presentation. These times didn't work out for her, but I'm gonna send the recording and see what she thinks.
Because we've discussed, I'm paid on one of the ID systems. We've talked to, some of them before, potentially doing QI work to improve outcomes in our patients, like with endocarditis that are going to require OPAC. If what are we doing currently and how can we kind of optimize maybe our patients that are going to AMA, but maybe focus on how can we actually address the addiction side of it to optimize outcomes as well.
Yeah.
So we don't have anything set in stone, it's just conceptualization at this point, but
Yeah.
Is that open to like individual bias, which is not like, I wouldn't demonize it. It's just like a cultural thing. We want to be careful, of course, if we give intravenous access to a person we know is regularly accessing their veins themselves. But at the same time, like, once we mark the patient as like a person who uses drugs, the reaction they get from healthcare in general, like historically, typically has been pretty negative. And I'm sorry, I'm Elise Stevens. I do addiction medicine at the Integrated Health Clinic. And I just want to say, Patrick, this was a really great, informative presentation, and maybe also in addition to kind of fueling protocol, like protocol descriptions, to limit, to minimize the possibility of like the entrance of bias into clinical decision making. In addition to that, I would say like internal medicine has to see this as well, because we also manage like, the whole part about addiction medicine being part of the, the inpatient experience, internal medicine can do that. They can also prescribe buprenorphine, and they are also educated on opioid use disorder, and, in order to get their DEA licenses. And we can really start looking at this endocarditis episode, this acute care episode, as an opportunity. That person who used drugs maybe doesn't have to use drugs anymore. Thusly, that PICC is even safer. So like you said, like the best way to protect that PICC is to help the person and treat them for their substance use disorder, which happens in the hospital and on discharge.
I think a lot of it is just the lack of that addiction care as well. Because if you don't treat the underlying addiction problem that got them in the situation in the first place, the situation is going to keep happening again and again, like you've seen in the qualitative studies.
Yeah, and that's kind of what we're, I guess, trying to play around with it too, is we have literature showing patients who do inject drugs who have PICC line use, they're not necessarily at higher, they're not, there's literature showing they're not going out and just abusing it, it's a lot lower. Same.
Yeah.
And then we have literature showing, hey, oral antibiotics are good in endocarditis. We have literature showing that. And then we also have literature showing, hey, if we give patients with endocarditis who are going to many oral antibiotics, they obviously do better than if we don't. It's something better than nothing. As long as it's a reasonable antibiotic. So trying to see that, obviously the addiction medicine part is very important, but then also what about the patients who were also just So I think there's definitely, and with our patient population here, there's definitely things that we can do to improve that. But I would say if you talked about endocarditis a lot during the presentation, so I would say that would be a really good place to start.
A lot of these complex infections like osteomyelitis, infective endocarditis, sepsis kind of overlap. So just trying to branch them into complex infections, but my main focus was infective endocarditis.
So this infectious endocarditis discussion is really like, I just kind of represents all of these other problems, but it's something tangible that we can look at, we can measure, and we can see like what the outcomes are. But really, it represents like all of the problems and complications of untreated substance use disorder. Yeah.
And I think further research into all of this might be a benefit for UMC as well. Because if we have it written down on paper for things that work, things that don't work, it can be a better step for improving patient care outcomes in the long run. So,
Loved it. Okay.
Thank you.
Bring it to everyone. Launch it.
Any other questions, Brenda?
You'd also be other IT pharmacists to go see it.
Oh, gotcha. Okay, gotcha. All right, if no other questions, thank y'all for attending. If y'all didn't get a chance to sign in, I can pull up the Zoom log and keep log on myself, so it's okay. Thank y'all for attending.